Hello everyone, welcome back to my YouTube channel. This is our first lecture from the Hematology and Oncology series, and in this lecture we will talk about anemia. Specifically, we will mainly be focused on microcytic anemia, okay? So, anemia on the basis of MCV is divided into three types. Microcytic, number one is microcytic, in which the MCV is less than 100. Normocytic, when the MCV is between 80 to 100. And macrocytic, when the MCV is more than 100. What is MCV? Is a mean corpuscular volume. Okay. When we do a complete blood count, which we also call CBC, um, we check hemoglobin, we check MCV, MCH, MCHC, red cell distribution width. So when we look at that report, we can distinguish, we can interpret what is the type of anemia a patient is having just by looking at MCV. Okay, in that report, if we see that the MCV is less than 100, we'll jump to the conclusion that this is microcytic anemia. Okay, so in microcytic anemia, there is hemoglobin affected. Okay, there could be two reasons of microcytic anemia. One is defective heme synthesis. We will talk about the whole cycle of heme synthesis. For now, I just want to highlight that our RBCs, red blood cells, has hemoglobin, heme and globin. Heme is formed in the part of the heme is formed in the cytoplasm. The cycle, the whole cycle, part of the cycle happens in the cytoplasm of the cell, and part of the cycle happens in the mitochondria. We'll talk about the heme synthesis cycle in the next lecture. Okay, so when heme combines with globin, it forms hemoglobin, and that hemoglobin carries oxygen to the blood, and that hemoglobin is present in the RBCs, and that RBCs is basically hemoglobin is carrying oxygen in the blood. Okay, so microcytic anemia can be due to two reasons. First is defective heme synthesis. Okay, there are three types uh, on the basis of defective heme synthesis. One is anemia of chronic disease, second is iron deficiency anemia, and the third is lead poisoning. If there is defective globin synthesis, heme plus globin form hemoglobin. If there is defective globin chain, then it will cause which type of microcytic anemia? Thalassemia. Okay. Now let's talk about iron deficiency anemia first. So, microcytic hypochromic anemia when the MCV is less than 100. Here, today we will talk about iron deficiency anemia, and we'll also try to cover alpha thalassemia and beta thalassemia. Okay, what could be the risk factors or reasons of iron deficiency? It could be due to chronic bleeding, not acute bleeding. Chronic, the person doesn't know that he's bleeding from GI or he's bleeding from uh, vagina. So, chronic excessive loss of blood chronically can lead to iron deficiency. Example, GI loss or menorrhagia. Second, malnutrition, when the person is taking less iron in the diet. Absorption disorders like celiac disease can lead to impaired absorption of iron through the GIT. Or GI surgery, example gastrectomy, can also lead to iron deficiency. Or it could be due to increased demand of iron, which happens usually in pregnancy. So what happens? And when there is a low iron or iron deficiency, it affects the final step in heme synthesis. The final step of heme synthesis cannot take place because of the decrease in iron. Okay. um, we will talk about heme synthesis pathway, but here, what is the final step? Final step is when protoporphyrin 9 combines with iron. I'm repeating it again. We will talk about the whole cycle, but for now, what is the final step? Within the mitochondria, when the protoporphyrin 9 combines with iron, it forms heme. So, because of iron deficiency, protoporphyrin cannot combine with iron and eventually cannot form heme. Okay, so when iron is not present, protoporphyrin cannot be combined with the iron to form heme. So in this way, final step of heme synthesis cannot occur. So then heme cannot combine with globin to form hemoglobin, and then hemoglobin cannot carry oxygen to the tissues and can cause certain symptoms in the body. Okay, when what test we'll do for iron deficiency anemia. First, and the basic test which we recommend to every patient, the best initial test is complete blood count. Okay, in the complete blood count, we'll see, obviously it is iron deficiency anemia, so we will see decrease iron. Okay, and we'll see when iron is low, the stores of iron is stored in the body in the form of ferritin. So when iron is low, ferritin would be low, would also be low. Okay, and ferritin, for the sake of your for exam purpose here, I want to highlight, you should remember that always ferritin and total iron binding capacity, they are vice versa to each other. So when the ferritin is low, TIBC would be high. Okay, iron is low, so ferritin would be low. When ferritin is low, TIBC would be high, because they are vice versa to each other. Okay, and then percent saturation is iron divided by TIBC. In the iron deficiency anemia, when the iron is low and TIBC is high, the numerator is low and the denominator is high, then the transferrin saturation will be low. Okay, because the numerator is low and denominator is high. And last is red cell distribution width. Some of the RBCs are getting enough oxygen, enough iron, and some of the RBCs are not getting enough iron. So some of the RBCs will be small, some of the RBCs will be large, some will be of the middle size. So the red cell distribution width will be increased. Normally, the red cell distribution width is normal among all RBCs. When some RBCs are not getting enough iron, so some RBCs will be small, some RBCs will be large, and that lead to increase red cell distribution width. There is, yeah. And then reticulocyte index, because we know that RBCs are formed in the bone marrow, and iron is required um, for the formation of hemoglobin. Okay, and when bone marrow is not working because bone marrow is not getting iron, so a compensatory mechanism in the bone marrow to produce enough RBCs is not taking place, that lead to decreased reticulocyte index, because the bone marrow is not forming enough RBCs. Okay, then we'll do peripheral smear. In the peripheral smear, we see RBCs are of small size and they have increased central pellar. There will be microcytosis, small RBCs, and hypochromasia, increased central pellar in the RBCs. Okay, there should be the image. Um, yeah, this image, the one A image on the left side. You can see the RBCs are of the small size and they have increased central pellar. There is pellar, but it is covering three-fourths of the RBC's diameter. The pellar is covering three-fourths of the RBC's diameter. So there is increased central pellar in iron deficiency anemia. Now, what would be the symptoms? Number one is fatigue, conjunctival pellar, pica is very important, because persistent, what is pica? The persistent craving and compulsive eating of non-food substances. Okay. And spoon nails koilonychium. Spoon shaped nails also, they are concave type of nails. Okay. This is called koilonychia. Let me show you the diagram to make things clear. This is the image. Figure 2.7. This is the image of koilonychia. You can see spoon shaped nail, concave. The finger plate is concave. Okay. By the way, this is first aid of step 2 CK. Okay. May manifest as glossitis, chillosis, and Plummer-Vinson syndrome. Plummer-Vinson syndrome is a triad of, I've remembered this triad as a DIE, D-I-E, DIE, which is dysphagia, iron deficiency anemia, and esophageal VABs. A triad of dysphagia, iron deficiency anemia, and esophageal VABs is called Plummer-Vinson syndrome. Okay. Now let's talk about the treatment of iron deficiency anemia. We give patient iron supplements, okay, usually from 6 weeks to 6 months, because it takes time to restore iron, restore that iron in the body, and oral iron is preferred over IV iron. Okay. Now let's talk about thalassemia. Thalassemia, there are two types of thalassemia, alpha thalassemia and the beta thalassemia. For the exam purposes, to make things easy, just remember that alpha thalassemia, there is gene deletion on chromosome 16, gene deletion, not mutation. In beta thalassemia, there is point mutation. Okay. In the on chromosome 11. Okay. Now there are four types of alpha thalassemia on the basis of gene deletion, or on the basis of um, if the one gene is deleted, it is least severe to most severe. It is divided into four types, the alpha thalassemia. The first is when one gene is deleted. You can see here, it's very easy. When one gene is deleted, one alpha gene is deleted, it is called alpha thalassemia minima. Usually the patients has no anemia, they are silent carrier, they don't have symptoms like fatigue, pallor, any kind of symptoms. Second type is alpha thalassemia minor, when is a deletion of two genes. Okay, two genes can be deleted from the one chromosome. If two genes are deleted from the same chromosome, then it is called cis. Okay, and if the two genes are deleted from different chromosomes, one gene is deleted from one chromosome and the other gene is deleted from the other chromosome, it is called trans deletion. Okay. Now, here the question arises, which type, cis or trans, which is most severe? Usually the cis type is most severe because both genes are deleted from the same chromosome. Okay. It leads to mild microcytic hypochromic anemia. Cis deletion may worsen outcome for the carrier's offspring. Okay. Third type is hemoglobin H disease, because when there is a deletion of three alpha genes, when three alpha genes are deleted, it lead to hemoglobin H disease. And in this also, hemoglobin H disease, there is excess beta globin chain formation. Okay, so it is moderate to severe microcytic hypochromic anemia. When all the four genes are deleted, it is called hemoglobin Bart's disease, the most severe disease, because there are no alpha globin, so there will be excess formation of gamma globin chains. It for gamma 4 genes. Okay, it causes hydrops fetalis usually, and it is the newborns that are incompatible with life. They usually die in utero. Okay, now let's talk about beta thalassemia. There is a point mutation, not gene deletion, in splice sites or Kozak consensus sequence on chromosome 11. Decreased beta globin synthesis or absent beta globin synthesis. When there is decreased beta globin synthesis, it will be shown as beta positive with a plus sign. When there is absent beta globin synthesis, it is beta with the zero sign. Okay. Increased prevalence in the people of Mediterranean descent. Usually thalassemia is seen in the patient of Asian and Mediterranean descent. Okay. So when one gene is normal and the other gene is in other gene, there is decreased beta globin chain synthesis, or when the one beta chain is normal or the other gene is other has a absent beta globin synthesis, it lead to beta thalassemia minor. There will be mild microcytic anemia and hemoglobin A2, which is because normal hemoglobin, the type of hemoglobin which is present in the adults is hemoglobin A, okay, with two alpha and two beta chains. When normal hemoglobin, which is hemoglobin A, is low, so the different other types of hemoglobin, which is hemoglobin A2 or hemoglobin F, their levels will get elevated in the blood. So in the beta thalassemia minor, the hemoglobin A is low. So to count to balance that decreased hemoglobin, Hemoglobin A2, which is 2 alpha and 2, I guess 2 alpha and 2 delta genes. You guys should confirm it. 2 alpha and 2 delta genes, they get elevated. Okay. Hemoglobin A2, level of hemoglobin A2 will be elevated. When both beta when both beta globin chains are, when there is a decreased beta globin synthesis in both chains, or there is a decreased beta globin synthesis in one chain and absent beta globin synthesis in the other chromosome, it lead to beta thalassemia intermedia. Is a variable anemia ranging from mild asymptomatic to severe transfusion dependent. Usually the traits, the hemoglobin minor, they are usually the patients are carrier and they don't have symptoms, so they don't need any kind of treatment. When the patients are asymptomatic and when the patients have like beta thalassemia major for suppose or beta thalassemia intermedia, they need treatment. They need blood transfusion. Okay. When there is absent beta globin synthesis on both sides, it lead to beta thalassemia major, and beta thalassemia major is also called Cooley's anemia. Is a severe microcytic anemia with target cells and increased anisopoikilocytosis. We'll talk about it, requiring blood transfusions. I've already told you that beta thalassemia intermediate, sometimes beta thalassemia, symptomatic beta thalassemia intermedia and beta thalassemia major, they require blood transfusion. Okay. And what is the best initial test? Best initial test for any type of anemia is complete blood count. Okay. And in the complete blood count, we'll see decrease MCV, decrease MCH, and decrease MCHC. Okay. And then we'll do the peripheral smear in thalassemia. In the peripheral smear, it will show microcytic hypochromic cells with target cells. Microcytic hypochromic red blood cells will be seen along with target cells in the thalassemia, which is usually not seen in iron deficiency anemia. Let me show you the diagram of peripheral smear. This diagram, yeah. Look at this diagram. Hypochromic small RBCs, microcytic. Increased central pillar and small RBCs, and these are the target cells. Okay. What is the most accurate test for thalassemia? We do hemoglobin electrophoresis. The most accurate test for thalassemia is hemoglobin electrophoresis. Okay. Now let's talk about the treatment plan. I've already told you that the carrier do not usually need treatment. The symptomatic in beta thalassemia and beta thalassemia intermedia and beta thalassemia major usually requires blood transfusion. But with continuous blood transfusion, it increases the risk of iron overload. And to counteract that iron overload, we give patient iron chelators like defroxamine, defrucerox. These are the names of defroxamine, defrucerox. These are the name of iron chelators which we usually give when we are giving excess or continuous blood transfusion to the patient of thalassemia, because continuous transfusion can lead to iron overload, iron toxicity in the body. So we to decrease that iron overload, we give patient iron chelators. Okay. I think we have talked enough about thalassemia. Before we go, I want to highlight the differentiating points between iron deficiency anemia and thalassemia. Okay, iron will be low in iron deficiency anemia, and the iron will be high in thalassemia. Okay, when iron is low, ferritin will also be low in iron deficiency anemia. But in thalassemia, when the iron is high, ferritin will also be high in thalassemia. Okay, I have already told you that ferritin and TIBC are always vice versa to each other. So in iron deficiency anemia, when the ferritin is low, TIBC would be high, total iron binding capacity. In thalassemia, when the ferritin is high, TIBC will be low. Okay, and what is percent saturation? It is the ratio of iron to TIBC. So in the iron deficiency anemia, the iron is low, TIBC is high, so percent saturation will be low. In the thalassemia, the iron is high and the TIBC is low, so the percent saturation will be high. Red cell distribution width will be high in iron deficiency anemia and will be normal in thalassemia. Okay. The peripheral smear of iron deficiency anemia will show microcytic hypochromic cells with no target cells, and thalassemia will show target cells along with microcytic hypochromic red blood cells. Okay, what there will be response to iron supplementation in iron deficiency anemia, because there is a low of there is a deficiency of iron, but when we give iron to the patients of thalassemia, there will be no response. So in this way, when you can check it, you when you when you're giving patient iron first month, second month, third month, and you see the patient does not have any kind of improvement, you should see that maybe I'm wrong, maybe the patient does not have iron deficiency anemia. You should explore the diagnosis and see if the patient has thalassemia. Okay, last and but not the least and very important thing is Mentzer Index. Mentzer Index is also used to differentiate between iron deficiency anemia and thalassemia. How we check the Mentzer Index? We do MCV over RBC count. You should know that mean corpuscular volume is less than 80 in both iron deficiency anemia and thalassemia. But RBC count is low in iron deficiency anemia, and the RBC count is high in thalassemia. So when I do the ratio, when I do MCV over RBC count in iron deficiency anemia, it will be above 13, because denominator RBC count is low in iron deficiency anemia. So the net answer will be high. Mentzer index would be above 13, 1, 3, 13. And in thalassemia, the red blood cell count, which is in the denominator, is high. RBC count is high. So the Mentzer index would be less than 13. In, um, in a nutshell, I would say that Mentzer index is below 13 in thalassemia, below 13 in thalassemia. You can remember this way: 13 thalassemia, below 13. And in iron deficiency anemia, it is above 1, 3, 13. Okay. Yeah, this is all about today's lecture. If you guys have any questions or if you don't understand anything, let me know in the comment section. Thank you.